Good afternoon. Can you hear? Good afternoon. We'll go ahead and get started in the interest of time. In the interest of time, we'll go ahead and get started and welcome for this third week of our end-of-life planning series. I have a couple of announcements, a few announcements. You will see these wonderful young ladies at each of the doors. Sue and I both have interns this semester and next semester. So, and to make it more confusing, one is Caroline, is back there. She is from Liberty University, and she is getting a degree in pastoral counseling. And then Carolyn is working on her MSW from NC State. So we are blessed to have them with us, and I hope you will get a chance to introduce yourselves to them as well. I had a question asked of me about where to view the previous sessions. This is week 3. The first week, unfortunately, did not record properly. So we missed the first week. But last week, you can find it on the portal under the videos section. You have to scroll way down through all the exercise videos. And then there's a heading called presentations. And you will see the previous end-of-life seminar listed, viewable. You can view it from there. I also want to thank, we do have handouts. Our wonderful library team. Thank you to Betty Bridges. Our library has put together a wonderful comprehensive bibliography of many of the books that have been suggested and asking several professionals in the community. We are very thankful. There's a display in the library right now of some wonderful books. So all of these topics can be further researched in our own library. And next week's talk is going to be Dr. Andrews. He is a psychologist, and he's going to be talking about ambiguous and anticipatory loss. When you move into Springmore and you miss your favorite garden that was at your home, that's an ambiguous loss. So he's going to be talking about these little losses we experience at this stage of life. I believe there was a question. Yes, Gretchen. So there's information, I'm just repeating the question for the microphone. So there's information on a wonderful public radio session about Parkinson's. And it's Dr. Dorsey. Ray Dorsey. And that's something that maybe Sue can pull together for the Parkinson's support group. We can look at that as well. I do want to introduce somebody who's familiar to us and who we all miss. Charlotte Jenkins was our clinic supervisor for a while, and now she's moved on to another facility, and we miss her very much. And Kelsey has been doing a wonderful job. But Charlotte also used to work for Transitions Hospice, and she has come back in her capacity to go ahead and share about palliative care and hospice care here at Springmore. So welcome, Charlotte, if you want to introduce yourself further.
Sorry.
Yes.
Cell phones off?
Yes. Yes, if people could please turn their cell phones off so there's not as many interruptions. Thank you. And in the event of an emergency, a staff will come and direct us, and remember the red poles as our gathering place.
Hi. Hello. Okay. I am so excited to be back here. Some beautiful faces. I've missed you all very much so. Those who don't know me, I was outpatient services director up until beginning of July or sometime in July, end of July. And now you have Kelsey Sloan, who was in the clinic as a nurse, and she is now taken that role, and have full utmost confidence in her, and I still keep up with her. So I still keep up with the whole team that's here, and it's a fabulous group that I was very blessed to work with, and blessed to work with all of y'all. Just took a position that was a mile from my house. So I have 3 teenagers, all in high school, and I was commuting about 45 minutes. So life before they go to college, right? And it felt like that's where I needed to be, but I miss you guys. My apologies on the handouts. I did get this presentation done right before I left, so that I could easily get to it when I came back. But I did not really have enough time to adequately get some of the handouts that I would have liked to. We can work on that with Kelsey, with getting some more of. I have a few, but I did realize today that I neglected to do that. So my apologies on that. But so just ready to get started. So I hear everything's been going great. This was a wonderful series that Sue and Lori and myself got together, and we did the primer at the Resident Association meeting in June. And I'm so glad that everyone has taken the time out of their days to come to these presentations, because it's going to happen no matter what, right? We don't have a choice. Life comes at us no matter how old you are, my age, younger, it's coming, right? And the more information you have will allow you to make the decisions you need to make for yourself. This is not about what your family wants. This is not about what your spouse wants. This is not about what the government wants. This is about what you want, right? So, but you got to do that with information, because, you know, we're not all rainbows and sunshine and unicorns and all that either. Life is life. So, that being said, we have this lovely cartoon presented, given by Mr. Jim Bundy. He brought that over to me. And this is, you know, guys, I know there's a lot of people that like to put off end-of-life decisions because it's an unpleasant topic. But I want you to know I've decided how I want to handle that phase of my life. Good for you, Rat. What have you decided? I will be avoiding death altogether. Oh, I should have thought about that. So who gets to avoid it? Nobody. The cartoon gets to avoid it. It can stay in its lovely paperness forever. We don't get to avoid it. So thank you, Mr. Bundy, for that one. I appreciate it. So what we're going to go over today is palliative care and hospice. So many times you're going to hear them as if they are one, and they are not. Okay? You'll hear, if you're in the hospital or you have a friend and they're like, oh, they're on palliative care. Oh, do you mean they're on hospice? No, I mean they're on palliative care. So palliative care is palliative care. Hospice is palliative care. Now, how does that all make sense? Meaning, palliative care, all hospice is palliative care, but not all palliative care is hospice care, okay? So palliative care says, I have a chronic illness. I want to continue treatment for my chronic illness. I want I want the oral chemotherapy drug. I want radiation. I want to continue on dialysis. I want all these things, or I want to look for curative methods for whatever it is that I have. And palliative care says, okay, that's great. Keep doing that. Do that all you want. But we're going to be over here in the sidelines, and we're going to help navigate the pitfalls, or help you navigate the pitfalls that come with that. So, the nausea, the pain, the fluid overload, if it's congestive heart failure, any of those things. We're going to help you navigate, because there is nothing in this world that you can put in your body that does not have a side effect. Do not believe that that isn't the case. Anything you put in your body, it will have a side effect. The side effect may be tolerable or it may be intolerable. That's what you've got to decide. So, therefore, palliative care is seeing the person beyond the disease, and it's a change in a healthcare mindset, okay? You will always hear me. I was an oncology nurse, second version of nursing. First was orthopedic, second was oncology. Oncologists are genuinely the most optimistic people on this planet, and they need to be. That is part of their skill set. That is what allows them to do what they do, and we need them to be that. But on the other side of that, you need that palliative care physician. And that palliative care physician is the most realistic individual that you're going to have contact with, okay? That's the person who says, yeah, do the treatment, but let's talk about what the side effects are going to look like and how can we help you manage that. And they're going to be the ones who say, probably talk to you a little bit more and be like, what are your goals in life? What do you want from this? So that's what palliative care does. And so a lot of times when someone that I love reaches out to me and asks me for help navigating something in someone's life, that they're in the hospital, a lot of times I'll say, get a palliative care consult. Because I don't know all the ins and outs, but that palliative care consult, what that does is you have a physician who can come in, look at everything, and say, okay, how does this all come together? And they are translating all the foreign languages that have been brought to you at the bedside in a hospital, right? Cardiologist is talking their thing, the nephrologist is talking their thing, oncology's talking their thing, palliative care comes and talks English. They bring it down to English, okay? So you may or may not be palliative appropriate, but it never hurts to ask for the consult. And so that is the piece of advice I always say, because they can genuinely say to you, yeah, you look pretty good. And they're not lying, okay? And I'm not saying anyone lies, but what I am saying is specialists look through things through their lens, right? They're only looking at their part of your body versus someone who's looking at the full piece. And a lot of people think that the hospitalist that's what they do. And it is. The hospitalist is also that person. They do that too. But they don't every once in a while you get a great hospitalist. I'm not saying, and they're all good. I'm not saying that anyone's bad. Every once in a while you get a hospitalist that will sit down and talk to you or with you, not to you, I should say. They're talking with you. They're not talking to you. Palliative care sits down and talks with you typically. That they're going to say, what are your goals? What do you want this to look like? What are you willing to go through? So they are a very underrated resource within the hospital. Yes, ma'am. So the question was on the topic of palliative care consults. When you're in the hospital, can you ask for it right then? You can. Typically, they're not going to, if you're in and out, like if it's a situation where you're in for like 24, 48 hours, probably not going to get a chance to see you, okay? But if you are there and it is an extenuating circumstance and there are a lot of things going on, then it is something to go ahead and say, hey, is there any way I can get a palliative care consult and have them help me navigate this? Absolutely.
How does this all fit in with the most form?
We're going to get to that. So the question was, how does it fit in with the most form? And we are going to get to that. I am going to go over the legal components of it too. So basically, with palliative care, you're using it when there's serious illnesses, many times multifaceted illnesses, such as someone who has end-stage renal disease, so kidney disease, along with congestive heart failure, along with maybe some pulmonary issues. So you've got multiple specialists who you are trying to work with. This is not when you go in for a UTI and someone is septic and it's genuinely very straightforward, okay, unless it goes in a direction it's not. But this is more for someone who's got multifaceted things going on, which, as we age, you do, right? You do. I mean, let's face it, your lungs are 95 years old. Your kidneys are 95 years old. They like each other, and when one goes down, they follow each other. That's what happens. So I'm a realist. It also provides, palliative care does provide support to the family and to the patients. And I think that just comes from asking what you want. Because when you have chronic disease and you've been going from doctor's office to doctor's office to doctor's office, and everyone's focused on your lab work and your pain levels or your other side effects, and they're not asking about you, it gets old. It gets real old, real quick. So when someone is asking about you, which is what palliative does, which is also another reason, by the way, we're bringing in Dr. Andrews to talk on next week, because it's important also to have, at this time, psychological help, because the head and the body don't disconnect. I know so many people think that they do, but they don't. If the head is good, the body goes good. If the body's going bad, the head's going bad, right? How we feel matters. But they're also going to help, like I said, manage the symptoms. But they're for someone who's still looking for that curative piece. It can be in the hospital, like I said, we talked about consults. But they can also follow you home, okay? They can follow, and you can also get this at home. You can ask. So if you're going through a long-term situation and you're just kind of hitting that piece where you're starting to wonder, is this all worth it? Why am I doing this? It is a conversation that you can have with your primary care physician and say, is a palliative care consult appropriate for me? And they can put in a consult and you can look at palliative care coming to your home. So that's also a possibility.
Are those physicians private practice, or are they working for the hospital?
So palliative care, she asked, are they private practice physicians? Palliative care physicians, they work for organizations. So for instance, Transitions has a branch of medicine that is palliative care. The physician does not come see you. It's a nurse practitioner that comes and sees you, and it's typically somewhere, they're not there every day. They're like there every 6 to 8 weeks. And they're kind of, sit down with you and say, hi, Miss Neal, Who have you seen in the last 6 weeks? Oh, I saw this doctor and this doctor. Okay, well, let's talk about what all that looks like, right? And then what of your symptoms, how have you been progressing in that? So that's what they're going to do. It's not a lot of hands-on care in any way, but it is someone who can kind of help you walk the path and walk beside you with that path. I will say that they don't stay with you for long periods of time because this is a Medicare benefit. Right? What does Medicare do? Medicare's great, but Medicare's going to go, okay, everything's going great. All right, bye. But they also may say, you need us a little bit longer, and they're going to stick with you, okay? So they're going to pay attention to how things are progressing. And then palliative care they do help you determine when is it appropriate to move into hospice? Okay. When have you hit your mark of, I no longer want to seek curative treatment? Because sometimes, I think we all can be guilty of this. We're hard workers. We put our nose to the grindstone and we just keep going and we keep trudging and we think it's going to get better the next day and we think it's going to get better the next day and we just keep rolling, right? Did it in your work life, may have done it with your family life. That is what sometimes happens when we're sick. I'm going to take my medicines and I'm going to do what I'm supposed to do and I'm going to keep going and I'm going to keep going. Why don't I feel any better? And this is just getting worse. So sometimes you need someone who walks beside you and says, maybe now's not the time, right? Maybe this isn't what you need to be doing now. Maybe you do need to be looking at hospice. So palliative care helps you walk through that to that point, okay? Sorry. On this one, this is kind of is palliative care right for you? And I think it went up there. Yep. Okay. And we're going to put this up because we'll put the presentation up on the portal. But this just is talking about, of course, it's not going to show it on my, hold on. Sorry. Yeah, you're going to, when we put this up on the link, this will give it to you. But this is palliativecare.org, and they basically have a questionnaire of, and I already lost it. A questionnaire of the different types of serious illnesses, so you can kind of do an inventory for yourself in a more personal situation. There's 5 questions that they look at, and I can't get it to scroll down. That's what I wanted it to do. Oh, daggone it. All right, I apologize. We will get that for you. Okay. Once again, going back over how do you get palliative care? A doctor's referral is needed. And they work with your existing providers. And then, like I said, unless you're in the hospital and you can ask for a consult. Keep in mind, when you're in the hospital, just a shocker, you're the one that's in charge, okay? It's hard to advocate for yourself, and this is the reason why I say, well, not just me, we say, find yourself a buddy. And some of that may need to be like a buddy that you might need to pay if you don't have a family member or you don't have someone who can't go and advocate for yourself. And Sue has resources for that. There are people that will go to the hospital and advocate for what you want. It's hard to advocate for yourself when you're sick. But you can advocate for yourself, and that's when those consults come into play. All right, so how does it work here at Springmore? That's what we want to know, right? So you're in independent living. You can make whatever choices you want to make, okay? We would like for you, if you do go with palliative care at any point, to let the clinic know, okay? Even if you don't utilize the clinic, right? So you may have an outside physician, and they do a consult for you. And so when I mean clinic, what I mean is Kelsey, okay? So please let Kelsey know. And what she's going to do, because this is the division in the clinic, the way it works in the clinic. All the nursing staff, we work for you, okay? Dr. Patel works for Raleigh Medical Group. So when people are saying, well, I don't use the clinic, please differentiate your, you can say, I'm not a patient of Dr. Patel's, or Ann. Ann works under Dr. Patel. So I'm not a patient with Raleigh Medical Group, okay? Or use the clinic, the nurses work for you. So letting Kelsey know what's going on with you lets her and Springmore help you, support you, and that's the reason why you're here. And it can be as little or as much as you want it to be, okay? If it's, hey, I'm just notifying you, I don't want you in my business, perfectly fine. If it's, hey, I'm notifying you, and I'd really like your support, then guess what? You have Sue, you have Jim, you have Lori, you have people who can support you and want to support you, okay? Yes?
If a resident is a health center resident, now, if you've broken your hip, you're coming back for rehab, you're up on that temporary. I had a kidney stone, I was up there until we got it squared away. Would I be considered, and I was on this?
Yes.
So pretty much, unless you're walking around in a bubble around here for 20 years, they're going to know.
Well, that's a yes and a no. So if we have had people who are dealing with things one-on-one. So your situation took you to the hospital. If someone's situation took them to the hospital and they came back on palliative care and went into the health center, you are correct. Right, but not even permanently. But that means we got your paperwork from the hospital. Then you're right, we would know. But sometimes people are having one-on-ones with their private doctors, and they make the decision to go on palliative care. And we wouldn't know that unless we are informed.
Okay, so unless I had said something in the hospital that I wanted to do, then it would come with the records.
Right. It would have come from the records with the hospital. Correct. You're right. So if you're living in your apartment, I don't want to put any bad diseases on you, but you're working with an oncologist, and the oncologist and you decide this is what you need, that's private. We have no idea. Okay? So that's why it does require anytime you're having those significant health challenges, it's very helpful to loop in Kelsey so that she can help you. Okay? Once again, as little or as much as you need. But sometimes
When you're up in the health center for a while, Dr. Patel is your
you're correct.
medical person.
So then we know. Right. You're correct.
So what happens to your outside?
I have a private physician.
Yes.
I not necessarily need Patel. No.
So Dr. Patel,
I'm not sure that relationship. Maybe this is not an appropriate.
well, no, that's fine. So what you're saying is, so the health center is a skilled nursing facility. It requires a medical director, and that is what Dr. Patel is, okay? So when someone is in the health center, whether they're permanent or temporary, he is your physician, and or Ann. They see each other. They go back and forth, okay? And now when you discharge from the health center, you go back to your private person. Does that make sense? Okay, so if you got a palliative care consult, and by the way, what we do try to do here, to let you all know, is we have in the clinic, we have access to Wake Med and to Rex. Duke is impossible. But we have access to their medical records, and we typically, when someone has something going on, we are trying to follow that, right? So that we know, oh, it looks like they're going to be going home. Oh, it looks like they're coming into the health center. Just trying to be prepared, right? And so a lot of times, you're right, we do know those things when someone's had to go to the hospital. But if it's a one-on-one just in your office, which the majority of the time it is, the majority of the palliative care consults occur in a doctor's office, not in a hospital setting, okay? So, or you were seen by palliative care, but they're not following you on the way home, right? So normally a lot of times we might not know, okay? But once again, we have some people who choose to be very private, and I respect that, and Springmore respects that, and that's okay. No one's going to put it out on social media, and it can be as private as you want it to be. I have had, I know Kelsey feels the same way I did. I don't mean to speak for her, but she and I have talked about this. I've had residents when I was here who absolutely wanted no one to know anything. And I absolutely 100%, that is what we should do, okay? I'm not giving out any information that's not needed. And so if that's the case, then that's the case. So understand, I think the biggest key to that is making sure that you feel comfortable that the medical staff, the nursing staff will keep your information private. It will be up to you to disclose anything. So then there's hospice. It's not about the number of days, it's about the quality of those days. And what do you get out of it? So what hospice does is a physician has to certify, gets a little godlike, a physician has to certify that you have 6 months or less to live to qualify for hospice, okay? Now, nobody has an expiration date on them, right? And this is just to the betterment of their judgment. No one can say this. When I was in hospice, I had a patient who was with us for 7 years. 7 years he lived. So who's to say? And in hospice, you can get discharged. We've had residents here who were on hospice and got discharged because they started doing better. Because it's amazing when you focus on the person, how a lot of times people actually get better. But you've chosen at that point to not do any more curative treatments. You aren't looking for a cure any longer at this point. Hospice is going to be providing support, a lot of support to the families and to the patient because it's a holistic approach. In curative medicine, everyone focuses on the patient. In hospice, we're looking at the whole lot of it, right? Because I can't be sick without it affecting my children, without it affecting my husband, and how they're handling it affects me. That's how that all works, right? It's all one. And so that's the beautiful thing about hospice. That's what I love about hospice is that it's about the unit, the support unit for that person. Focusing on managing the symptoms of what's going on. The pain control, the emotional well-being, uncontrollable side, whether it be nausea, whether it be sleeplessness. A lot of times sleeplessness is a problem. Agitation is a problem. Trying to navigate those things that make people uncomfortable. The way hospice works, you have more visits in hospice than you do with palliative care. With hospice, if you take nothing away from this presentation, what I want you to take is you will be offered, if you ever do a hospice, you will be offered a social worker, a spiritual care person, and a nurse. Take all three. It's meant to be, it's a three-legged stool. It's meant to be a three-legged stool. Medicare actually believes in it and pays for it. So you know it actually has to be worth something, right? So many people are like, well, I only want the nurse. I have a minister, and I don't have any social work needs. Well, that isn't necessarily true. And the reason why I say that is, A, you're going to get more visits, right? Because they all are going to visit you. So you're going to see more people, have more support. Spiritual care is exactly what it says. It's spiritual care. It's not religious. You might feel more comfortable talking to someone who you don't really know and accepts you where you're at than your minister for 50 years, right? Maybe I'm questioning God. Maybe I'm really mad at God. Maybe I hate my children because they're not doing what I want them to do, right? But I'm not going to confess that to my minister of 50 years. But I will talk. It's a lot easier to talk to people, right? And these are things that come up, and they're hard. So accept the resources. If you, after a while, say, no, I don't need you right now, they'll go away for a little while and come back, okay? So the nurse comes once a week, once every week to 2 weeks, depending on where you're at. Typically, they start off strong. You start seeing them every week. And then maybe you're doing fine and you don't really need to be seen every week. And so they have to, by Medicare guidelines, see you every 2 weeks. But then as things increase, as symptoms increase, as you decline, they start increasing their visits, okay? And they start showing up a little bit more. Social work, I believe, is every 2 weeks, and spiritual care is once a month. That's per Medicare guidelines. A lot of times you'll see them more frequently than that, depending on what's going on. They're going to help you make sure all your ducks are in a row. But it's a team. Let the team work for you, okay? And it's patient-centered care, so it's what you need. And maybe you don't even talk to the social worker. Maybe the social worker only talks with your son who's in Washington State, who just needs to talk on the phone to somebody about the fact that they're remote and they wish they could do more, right? It's for the whole team. There's two different types of hospice care. Majority of people will be in the home, okay? We have had quite a few people here at Springmore who have had family members at the hospice home. That is what's called GIP, General Inpatient Care, okay? That is hospital level care. That's because those symptoms could not be controlled in the home for whatever particular reason. We're going to get to that because I'm going to what it looks like here at Springmore. Absolutely. But this is, so the whole point is if it's in home, then hospice can help manage all of the symptoms going on in the home, okay? Where you currently live, whether that be independent living or the health center, okay? And then, of course, like I said, general inpatient. Here in Raleigh, you have a choice of going with any company you want to go with, okay? That's the case. The other piece of advice is, one of my other pieces of advice that I tell people is, always go with the company that operates the hospice home in your area, okay? So here, it's Transitions. Not just because I worked for Transitions, not just because I like Transitions, but every hospice company is required to provide general inpatient care. If you go with another company, they're going to provide that in the hospital. Well, the whole point was to not be in the hospital, right? You didn't want to be there. So if you were in Chapel Hill, it would be UNC Hospice because they operate the one in Pittsburgh. If it's in Durham, it's Duke. They operate the one in Durham. So that's the piece. The goal is always to be in the home, but if you have to go to general inpatient, then you want to be in the nicest environment possible, and the hospice home is beautiful. For a hospital, it's beautiful. My mother died there. So I've had the experience of working and experiencing it as a family member. And it is as nice as it possibly could be for an absolutely horrible situation. But it's a place for privacy. It's a place for people to experience end of life together. So what does it look like here at Springmore? And the confusing part of what does in-home mean? So one of the hills that I climbed and was willing to stand on here was that you get to be wherever you want to be. And yes, I've talked to Kelsey on that too. Kelsey feels very similarly, and Springmore administration feels that also, is that if you can manage hospice in your apartment, and we have had several people do that successfully, then that's okay. If you want to be in your apartment, you should have the right to die wherever you want to. Now, it's happened many different places, many different scenarios have occurred here at Springmore in my time. It's all about what your resources look like. And when I mean by resources, I mean your physical resources, your financial resources, your emotional resources. All of those resources have to come into play. So we had a resident whose family was in Georgia, so they physically could not be here. But however, she had the financial resources and she had the manpower behind her to make hospice work for her in her apartment. So they got round-the-clock care. They paid for it. They arranged it. They did all of that. We checked in, obviously, multiple times a day. But we weren't the ones organizing it. They were doing that for her and making that happen. We have had it such that a couple together, they want to be in their apartment, one spouse on hospice. The couple wants to be together as long as possible. They successfully did that for as long as they could until the other spouse decided they could no longer care for this person. And at that point, that person went to the health center and died in the health center. Okay? Because that's the beauty of being here. You have the health center as your backup. Right? And that can happen. Timing is key. Right? You can't move someone at the very end of life. Can't happen. I don't care if it's just down the hall. It's not. You have to plan. And that's where looping in the staff here at Springmore is very critical, because that can be walked through. We see the hospice nurses come into the clinic on a regular basis. There is conversations about what is going on at all times. Now, it's not for us to get in your face about it, right? because you deserve to have what you need. But we need to know what's going on, okay? So that we have your back. And so what I did and what Kelsey plans on doing is just checking in with whoever that is, right? How are you doing? How are things going? Tell me when you need me. Pick up the phone when you need me. Once again, as little or as much as you need. And it's okay to just say, I don't need you. I got this under control. Because we've also had that. We had a gentleman whose family was from all over the country. They signed up shifts, and they got it done. And they were here, checking on him, taking care of him, and that was great. They didn't involve us very much. We're here when you need us, okay? So it's, once again, what fits you. There is no outline on the way this has to happen. But it will be more successful if you talk with the resources you have on hand, because you guys have made great choices, because I do love this place. You have a wonderful, wonderful team of people who are willing to support you in whatever those decisions are. You just have to talk about it. Uncomfortable situations, uncomfortable conversations, and I understand that. So yeah, sorry, went through this. The physical support, the emotional support, and the financial resources. Those are the three things that you've got to have to make it happen. And if you don't, let me go back to, so for instance, I want to go back to this piece. We've also had it such that someone can be on their own, and they made the decision to come into the health center until they were at the point when their children would have to get involved, because they did not want their children to physically have to support them. They wanted them only to be emotional support when they were in the health center, right? So that also goes back to, what do you want? I'm not comfortable with my son wiping my butt, because that's what it gets down to. I'm not comfortable with having to put my daughter-in-law in the place of giving me medication, because that's what it comes down to. So really analyzing what your resources are.
Who determines the emotional support being available or declining?
You do.
Okay, so obviously, physically, it's provable. If you're physically declining, emotionally or financially, you look at the bank account.
So the question...
Emotionally, yeah.
So the question is about the emotional support. And what I mean by that is the emotional support is, so there's the physical support, right? I need 24-hour care, right? I need to have people here. What do you need emotionally? Not everybody needs the same thing, right?
Not everybody has a big family.
Oh, of course.
But that doesn't necessarily mean they don't feel
Of
well and emotional.
Absolutely. And that's what I mean. It's up to you.
So that would be, as long as
It's not Springmore coming in. It's not Springmore saying, oh, you don't have enough emotional support.
sending you to a psychiatrist.
Oh, no. No. It's the choices of, like I said, a resident making the choice of, she wanted her children to be there purely emotionally rather than physically. And she didn't want them to be there both ways. That was her choice, right? And so, no, this is all about the things that are going to determine it from a Springmore standpoint. Are you safe? Number one, are you safe? Are you cared for? That's it, right? Those other three things are about what you want and what you need to look at. I'm sorry, what was that?
What if your financial resources are diminished?
So the question is, what if your financial resources are diminished? My personal piece is, if your financial resources are diminished, 24-hour care is extremely expensive, and you have the benefit of the health center. It may not be what you really want, but that's part of what we have to decide, right? We have to look at, and timing is everything. Is this going to be long hell? Is this going to be a very slow decline? Like I said, I had someone on hospice for 7 years. I'm not saying that would be the case, but it might go on way longer than we expect. And so understanding what that might potentially look like, and then figuring out, how does that all work together, those three things. But the beauty is you have the health center. In the health center, by the way, many of y'all are aware that we have the angel room. And the goal of the health center staff is always going to be having someone at the end of life be able to be in the angel room. Okay, the angel room is a little bit bigger, it's a little bit nicer, and it's private. Obviously, that doesn't always occur or can occur, depending on, you might have multiple people who are dying at the same time. It happens. And there is only one angel room. That is correct. Because most of the time it's unused. Thank you, God. Right? Well, not unused. It's not being used for that purpose. It's being used, but not for that purpose. So it's a tricky thing that they manage in the health center, and they do a beautiful job, absolutely beautiful job doing it, and are very sensitive to people's needs at the end of life. Having worked with hospice, and actually was familiar with Springmore from hospice before I came here, they're very welcoming to the staff, hospice staff coming in. And so that's also very beneficial for you as a resident. So like I said, hospice is going to be coming in, but Springmore staff are the ones who are going to be providing the care when you're in the health center. The nurses, hospice nurses, are just going to be coming in and checking in on you and seeing how you're doing and how everything's progressing. And basically, let's face it, it's because we all matter. All of this is, so you matter because you are you, and you matter because it's the end of your life. And that's actually how I wish all healthcare was. I'm going to put my rose-colored glasses on and be like, that's how I want healthcare to be. You matter because you are you, and we should be focusing on you. Because that's what makes a healthy person, is a person who's attended all the way around, all parts of us. So, questions? Anybody? I know we kind of took questions as we went along. Anybody else have anything that I could help with? Yes, Sue.
I just wanted to let you know, if you're a caregiver of someone, of a spouse, partner with dementia, there is now a program called the GUIDE model. It's a pilot program that Medicare has set up, and Transitions is actually the provider in our county. And you can be in independent living even in Springmore. The benefit of that is that you get targeted dementia support through a social worker, so education about the illness as it progresses. But you can just call, our mother-in-law is on that program, and it's really helpful. Just to better understand the disease process. But that is a part of palliative care. That is a new program with Transitions, and they can meet you here in independent living. So you would just call Transitions, talk to the clinic, and again, it's just a doctor's order. But I found it to be very helpful, and it's called the GUIDE model, and it's a pilot program under Medicare that it's really kind of providing caregiver education and support.
Yes, ma'am. Oh, yes. Sorry. You're right. Oh, we didn't show that. Okay, so the most form. I heard that you talked, legal came by last week, right? Gave you some good information. Let me explain why the most form is so important here at Springmore. The most form shows what kind of interventions you want to have, right? And so here at Springmore, if the nursing staff comes and sees you, it's part of what we give to EMS. We give them a whole packet so that you don't have to take your purse and you don't have to take your insurance cards and you don't have to take anything with you. It's all in that packet. And one other thing is it tells EMS, if EMS doesn't have that, they're going to assume you're a full code, right? And that's why we are very much wanting to have that. Full code. They're going to put every intervention in place. They're going to pound on your chest. They're going to break your ribs, okay, to bring you back. And unless that's what you want, we really need that most form. It's the bright pink form. We like to have 3 copies. 1 copy stays with you, 2 stay in the clinic. And technically, the hospital is supposed to send those back when you go to the hospital. That doesn't always happen. So we do audits consistently, looking for missing pieces, or we found them without physician signatures. And guess what? That is no good. If it doesn't have a physician signature, it is not legal. But yes, that's why you want us to have that, so that I, as a healthcare professional, since I'm going to also show up in your apartment, if I see something and you're on the ground, I want to know what to do. I want to know what you want me to do. Let me tell you that. Not, I know what to do, but I want to know what you want me to do. Yes, ma'am.
Now I'm just having a brain freeze. The back of the most form can be updated every year. You see your doctor and you say, I still want stuff the same, and she signs it again.
You can update it as many times as you want, as many.
My question,
Okay.
you all have the copies that you're going to be looking at. I have one on my fridge.
Yep.
I could take care of that myself, but do you kind of send a reminder to people saying, it's almost a year and your thing needs.
We do not. We do not tell people to update theirs, because that should be a personal choice between you and your physician. We just say we've got it or we don't have it.
So you would follow it even if.
Oh, it is a valid document per North Carolina. It is a valid document as long as it has a date. Doesn't matter if it was 5 years ago, and a physician's signature and your signature. Then that's a valid document for me.
Okay, so that back part is more about if you want to change what you.
Yes, it is, and that's totally up to you.
And Springmore needs 2 originals.
So Springmore does like to have 2 originals. The document is not legal unless it's the bright pink form. Photocopies are not, they don't care about that. We got to have the bright pink form.
Specifically, who has them? Do we see? I want to see what you have.
You can come into the clinic at any time, and Kayla's at the front desk Monday through Friday, and you can just give her your name, and she'll go and pull the form for you, and you can look at it.
Separately, the lady last week said something to the, she said it specifically, that the yellow form was better. What's the difference?
I understand where she was coming from. The yellow form is called the goldenrod. The goldenrod used to be the gold standard, right? That used to be the thing. In the last 10 years, it is now becoming the most form is becoming more recognized because it is more detailed in what you do and do not want. So, meaning, if you arrive at an ER and you've got a goldenrod that says DNR, do not resuscitate. Okay, I'm not going to resuscitate you. but I might give you IV fluids. I might do IV antibiotics. I might put you on a respirator. I might do lots of things without having to do CPR. The most form says, I don't want CPR, but yeah, I'll be on a respirator, or I don't want to be on a respirator. I don't want IV fluids. I don't want IV antibiotics. Like, it is more detailed in telling people what to do. And people ask me the difference between a living will and a most form. A most form is a physician's order, okay? So nobody's going to go dig through the files to find your living will. If something's going on with you, we're just going to go find that doctor's order. And so what I say is the most form is all about the emergent, what's happening in the moment. The living will is what happens after they've gotten you settled, and now they're going to go through and get your living will. I'm not saying they aren't important. They are. The living will is very important. It's just one is in the moment and one is after you've gotten through the emergent situation. Does that help? Okay. No? Okay. So the DNR, or the most form, so I'm going to hand it to EMS, right? And EMS says, okay, I'm going to do this, this, and this for this person, right? I'm going to give them some IV fluids in the truck, which they can do. I could even start IV antibiotics if I get an order for it. They can do that. They're going to do all of those things in the moment. They're going to get you to the ER. They're going to do all the things that are on that order to do, right? Now let's say you have to go to the ICU. Now you're stable. You're sitting in the ICU. They've done all the different treatments. Now someone's going to go get your living will and say, oh, this is what Miss Bullen wanted. Okay? And now they're going to follow that. Okay? One's in the emergent moment, and one's after you're nice and settled and stable. Okay. Yep. Yes, ma'am.
And we have been asked to keep that notice on the side of the refrigerator.
You can keep it wherever you please to keep it. Just know where it is. Okay? Because not everybody wants to see a bright pink form in their face every day at breakfast. We're going to give it. We've got that taken care of. That's the beauty of being at Springmore. We got you covered. Yes, you can, and I'm not saying that isn't a bad place. What I am saying is if someone says, I don't want to look at that, I don't want it on my refrigerator, I'm okay with that. I just need to know where it is. It can be in a drawer beside the refrigerator. Some people don't want to stare at that every day. It's all about how you see life, right? Yes, ma'am.
Clarify, somewhere I got in my mind that if you didn't have the most form, for some reason they couldn't find it, once EMS starts a line on you, or a feeding tube is started on you, that they cannot remove it, even though maybe a doctor's order they could remove.
They'd have to do it with the doctor's order.
Yeah, so just your advocate say in the hospital saying she didn't want that, and here's the living will that says that.
Oh, yeah, no.
It has to be a doctor's.
Yes, but your living will is going to get that doctor's order.
Okay.
Yes, it still has to be a doctor's order, but
If by mistake they start it, there is definitely a fairly quick way to get it out of there.
as long as you're digging up your,
The doctor's,
you have to have your living will, you have to have your advocate, and then you're saying here, and the doctor says yes, and then they discontinue. Yes. Whatever life-sustaining measures are involved, yes.
So a healthcare power of attorney, the person that has that, could do the same thing?
Yes. Healthcare power of attorney is the person, and the healthcare power of attorney does not kick in until you are unable to speak for yourself. Okay? A lot of people, a lot of children, I'm one of them, I'm a healthcare power of attorney. It doesn't matter until my daddy can't say anything. Okay? But a lot of people think it does. That's the key.
We had a question back.
Yes, ma'am. Miss Neal.
I was just going to make a comment. Years ago, when all of us were taking care of our parents for the most part, getting that NG tube or that whatever taken off, even though maybe you had power of attorney, could be very difficult.
It can.
But nowadays, people are much more amenable to listening to what we want rather than what happened in that emergency.
Absolutely, and I agree with you. However, I'm not going to rule out that stubborn physician who thinks he can save you and you don't want to be saved. So get the most form. Tell them exactly what is stated there. That's why we love it. That's why it's important. So much so that, guess what I'm doing at my new facility? I'm making sure they got their most forms. Yes, ma'am.
So you're under hospice care,
Yes.
but can you get explanations for what's going on?
So the question is, if you're under hospice care, can you get explanations for what's going on? Do you mean what the disease state is and like what is physically happening to you in the moment?
You know, for example, my husband's scalp became covered with scabs.
Okay.
I suppose I want to know why he's having so many scabs. It's squamous cell cancer, but it's not invasive.
Okay, so the question is basically if something's going on, can we find out the why? Right? So you mean some type of test or study or blood work or whatever. Can you do that under hospice? Is that the question? Manifest. Okay. So that's a yes and a no. And this is the beautiful thing I love about hospice because it's changed the way I think about life. Why? Why am I going to put somebody through a CT scan? Because what am I going to do about it?
Well, right, I get that. I suppose you just want an explanation of what's going on.
They can give you a lot of times they're going to know, right? They're going to be able to tell you what's going on. But sometimes there are going to be things that require certain tests that may be invasive. If they're invasive, they're not going to pay for it, okay? Because the whole point is that you've gotten to the point where we're not looking for curative treatment. So if we're not going to do curative treatment, then why are we going to go try to figure out what's going on? And so one of the things about hospice is a lot of letting go of the whys, letting go of how did we get here? The point is we're here. The point is we're in the moment. Let's focus on, are they comfortable? And that's what matters. Is that person comfortable? And that's hard. That's probably the hardest thing about hospice for families is letting go, because typically by then you've been through a very long health journey and you've been trudging along trying to find out what can we do to cure this? What can we do? And now you've hit the point where there's nothing to do.
I had experience with hospice with my mother, and they overdrugged her.
Okay.
And when I drove to Asheville, she was non-responsive. I mean,
Okay.
she was breathing, but they were supposed to give her more pain medicine. And I said, we're not giving her anything.
So the question is that she had an experience where she felt like her mom was overdrugged on hospice. And that's really easy sometimes for people to think. Understand that morphine, the main drugs that are used in hospice are morphine, Ativan, and Haldol. Morphine is not used for pain. Morphine a lot of times is used for shortness of breath. So it is not a matter of that they're in pain, but if they start to breathe very fast, which, by the way, there's no one on earth that can breathe 32 times a minute, who's comfortable. Okay, it doesn't exist. That's respiratory failure. So you give them morphine and it slows it down. And it does sometimes look like they're overdrugged, but it might not have been. And I don't know. I don't know that situation. But there's a very good chance that they weren't alert and oriented. But this is also where it's important for you guys to tell your loved ones what you want. And what I mean by that is my mom, when she was on hospice, told me, knock me out. I do not want to be in pain. I do not care if I can talk to you or not. I said, thank you, I love you, and that's what I needed to know. And guess what? She was knocked out. I made sure she was knocked out because I did not want her to not have what she wanted. It wasn't about me at the moment. It was about her. There are going to be some people who say, I don't care if I'm in pain. I want to talk to my loved ones, and that's okay too. So that's what it's about, what you need and what you want, and making sure everyone around you knows that. Because guess who's going to be done when you've died? We don't know what happens after this, right? When we got our thoughts. And I always told my nurses this. Guess who remembers that death for the rest of their lives? The people who love that person. I will forever know what it's like to be at my mom's bedside. And it's the best gift I was ever given. For me, I needed that. But I know that I did what she wanted me to do. And so don't leave your loved ones with the idea of not knowing what you want. Because that's hard to question.
Could you mention what hospice will pay for the palliative care will not?
Everything's different, depends on the hospice company, because they get one blank piece of money from Medicare. They have to manage it, okay? And each hospice company decides what they will and will not and how they manage that. Typically, incontinence supplies are paid for, or they'll pay for like what they think 2 weeks worth is. But sometimes people, if let's say they're on Lasix, they go through them a lot quicker, right? And so they don't pay 100% of what that is. They pay for all the medications that are related to the diagnoses. So they're not going to pay for, if you're on for congestive heart failure, they're not going to pay, I can't think of what they wouldn't pay for, but it's going to be related to the diagnoses. They are not going to allow, you will not qualify for hospice, just to let you know. If you're taking most of the time, if you're doing any type of curative treatment, such as an oral chemotherapy pill, they're going to say, we're not going to pay for that, and you'd have to stop that in order to come on to hospice. And someone could say, well, I'll pay for it out of pocket, until you find out it's $15,000 a month, which is the reason why they're not paying for it, because they can't afford to. But they won't call it, well, yes, but that's the thing. Even though you most likely have less than 6 months, it's still that oral chemotherapy pill. So a lot of times they will pay for things like palliative radiation, because that's not curative, it's pain control. Sometimes they may pay for someone who has a blood disease. They might pay for a couple blood transfusions, but they're not going to pay for blood transfusions ongoing, right? Because that's a curative, it's not a curative piece, but it's going in a route that's not considered hospice mentality, right? It's not curative, but it is life-sustaining. Because some things aren't curative, they're just life-sustaining, such as dialysis.
If you've got a transition hospital facility, who pays for that?
So the question was, who pays for if you went to the general inpatient hospice home? Medicare. That's all under your Medicare benefit. Mm-hmm. And then like physical therapy, things like that, typically are very minimal. Because once again, it's not because they're trying to be cruel, but typically at the end of life, you're looking at energy conservation. Can you really tolerate, if you're at the end of life, can you really tolerate a 45-minute PT session? That's, one of those things. Anything else? Anybody else? Anybody else?
What is the education to be a palliative whatever?
A palliative whatever? A physician, you mean? What kind of training do they have? Well, palliative is, it's just like, so palliative and hospice physicians are just like any other specialty. Regular, they're an MD, and then typically they've done some type of fellowship.
Is there something to say residency and
Yeah, absolutely. We used to have residents over in transitions. We would have residents. We had physicians doing residencies. And then some of the bigger, Yeah, well, I think it's just because it's growing. It is a growing profession. And another thing that you're going to see a lot of times, one of the side effects, I just bring this up, is de-escalation of medications will occur during a lot of times when you're on hospice. And people get upset and they're like, oh, you're taking away my meds. Well, there's a reason. And it's not because people aren't trying to cure anything. It's because it's energy conservation again. Why are you going to take lisinopril? Lisinopril is meant to control your cholesterol for the next 10 to 15 years. Why do you need this? If you don't have to take 10 pills every morning, isn't that better, right? Why are they going to take away Eliquis, right? They might take Eliquis away because you are at risk for a fall and they don't want you with a subdural hematoma, right? So understand that that's also a misconception with hospice. I have gone way over, but one more question. Yes?
Palliative, the group that you showed up there on that website, to read more about palliative.
Yes.
Would that be a good source? And could you send out, do you have any other organizations that are working with that and explaining it to people? Because it's new to me too.
Yes.
And I'm really excited about it.
Yeah.
Because, wow, yeah, this is what I've been looking for. For later.
Of course. No, palliatives.
But to put it all together because of this affects this, and I'm starting to see that. And I would love to have some sources.
Yes. I will definitely work with Kelsey to try to get some things out. And like I said, I think if I'd been here, I would have had that together, and I apologize. All right. Well, I have more than taken up all of y'all's time, and I greatly appreciate y'all coming out, and it was a joy to see you all. Thank y'all.